Good morning, Drs. Burney, Drs. Maury, guests. There's nobody that I pity more in 2024 than a Chicago White Sox fan. But right behind that, it would be Professor Ziegelman. And it's because he has an indefensible debate. And I truly feel for him. But we are going to try to make this intellectual and academic and see if he has a way to sway me. I do have a disclosure to grant support from Boston Scientific and Endo. I forgot that slide. But let's go into this. My role here is to persuade an audience full of people that probably need no persuasion to provide an FDA-approved therapy in a field where there are no other FDA-approved therapies. So if we take the bona fides of the FDA and say that we believe in them as a governing body to keep us out of trouble, then this debate probably is over already. But let's just say, for argument's sake, and for the historians in the audience, that we should talk about verapamil and interferon in the age of collagenase. So the history of this does go back years. Dr. Levine was one of the first to publish on the use of verapamil, which is essentially taking a calcium channel blocker because I guess there's calcium in the plaque, and maybe it's an anti-fibrotic property, but essentially what you're doing is making an 18 or a 21 gauge pin cushion out of a penile plaque. So you're quilting it with verapamil. You can probably quilt it with just about anything and show some degree of improvement, or a patient that never wants to come back and see you again when you're putting 20 milliliters of fluid into their penis. So with that in mind, that's our verapamil studies, and the interferon history is somewhat also historical. This is great. So you take a drug and put it in a penis and then give somebody a flu. That's sort of the history of this. It's a little bit more precise, I guess, and a little bit less volume of injection. But the idea is that you're trying to upregulate the immune system in a way of fighting fibrosis. And if you think about the process of Peyronie's being a profibrotic state and the cytokine cascade that ensues when somebody decides to lay down type 1 and predominantly type 3 collagen, then maybe what you're going to do is take something that's even more pro-inflammatory, put it in the penis and say, what the hell, let's see what happens. And so the studies of that go back years as well. So let's talk about it, because I'm sure that my professorial colleague is going to show you the efficacy. And so in any good debate, you want to sort of look at the other side and be somewhat understanding of their plight. And so there are some interesting outcomes that maybe verapamil has some improvement in sexual function, penile curvature. Really no randomized trials to discuss whether that's a deal. And most of the time, when you look at the literature around verapamil, what are they doing? They're combining with oral medications that we know have some degree of antifibrotic properties, most predominantly probably the PDE5 inhibitors. And then what else are we doing? We're combining with a mechanical device, some kind of traction. So think about that when we then talk about what else is out there on the market where we have good randomized controlled data where the only traction is 90 seconds of stretching a day with no mechanical devices, and that's what we're comparing verapamil and interferon to. So great data out there. I think when you find somebody, our Peyronie's patients are probably some of the most motivated people that we will take care of, and I think we can stand up against even our oncological colleagues and say, these men want to get better, and we know that as sexual medicine specialists. So if you're investing in their care and you've got nothing else in your toolbox and you say, hey, this is going to help, maybe it's going to help. What about interlesional interferon? Do we have efficacy on there? So the interferon data show maybe a 20% reduction in curvature, and that does stand alone. So there is some degree of efficacy that is around about the placebo level of what we see with a randomized placebo-controlled trial for collagenase. So it may benefit. There may be some outcomes that will help guys feel like they have investment in this as well. But bottom line is there's no FDA approval for this. There may be some improvements, but there's some risks, right? A lot of risks associated. Risks that maybe urologists shouldn't be taking care of, whereas the risks we know with collagenase, that's our wheelhouse. And so if you look at this, the flu-like symptoms, the hypotension, I mean, you're putting most likely with verapamil, you're putting a blood pressure agent. I mean, it's very difficult not to get some of this in the cavernosal space. And we know that other than an interosseous line, cavernosum is a great way to introduce systemic drugs. So you're going to put a big bolus of a calcium channel blocker into a guy's corporeal tissue more likely, so then actually into the plaque. Variability is, as we know, it just depends on the study. And again, without randomized data, I'm not sure how Dr. Ziegelman is going to gaslight you here. The unpredictable nature of treatment can produce anxiety and depression in patients. And this is a commitment. And this is not just a one-time thing. There's multiple sessions, multiple hematomas, multiple office visits for not a lot out there. So what have we been doing as a society over the last 30-odd years? Well, we've been sort of minimally publishing on verapamil, 140 publications since 1991, 85 for interferon. And then since the approval of collagenase in 2013, we've doubled those numbers. And so obviously there's a lot more data out there, and this is why it's a little bit easier to defend, not only with the imprimatur of the FDA as well. So let's look at Dr. Ziegelman. And if you believe what you believe, here's this. I mean, I would believe this guy. He could sell me a car. He could sell me anything he wanted, except for maybe 20 milliliters of verapamil in my penis. And he's publishing a lot. And so what you're seeing in this age of elections is a guy that flip-flops. This guy is a flip-flopper. This is what he does. He tells you one thing, and then he comes out with something entirely different. And so it's disappointing, really, in a plenary session to have somebody of his status trying to defend something that's indefensible. Okay, so he's going to shoot down this next slide, and I'm ready for it. That's fine. I'm sure there'll be time for questions. But let's talk a little bit about why we shouldn't be even talking about verapamil and interferon anymore. And it's because we do have an FDA-approved therapy, so it does give us a little bit of legal ground to stand on in case you give somebody, an ICU-induced virus and flu in an interferon treatment. That's hard to defend. So these are off-label, and obviously in our tool chest, most of what we do is off-label. So I'll give you that that's kind of a weak argument. We wouldn't be here as a professional society if everything we did is on-label. But we have a targeted mechanism with basic science data that go back to the 1980s. I mean, this even before we were doing verapamil and interferon, Marty Gelbard was in his garage doing collagenase treatments as a resident at UCLA in the mid-80s. And so we know the track record of collagenase. We know what it does, we know what it doesn't do, and it's very reliable. It's exactly the same drug every single time you inject it. The proven efficacy is there. We know the IMPRESS data. I'm not going to bore you with that. But there is this idea, I think, that is really important, is that you offer what we coin the metaphor is probably Irwin, because he does all great things. So if I give you credit, you're welcome. If I stole it, somebody tell me. But we called collagenase when it first came out a biological scalpel. And I think there is something to that. You're offering something that actually causes destruction, which is what we do every time we make an incision. We destroy something, and then we put it back together. This is all doing it through 0.25 or so cc's, sometimes 0.39. And that is what gets us the outcomes that we're looking for, a reliable option. The other thing, of course, that he has no data to talk about is that there is an improvement in bother score. People feel better, and even if their curvature doesn't improve as much as they'd want it to, they do better from a psychological standpoint going through with a proven treatment. So that's really all I have. I mean, this is kind of silly. I feel bad for the guy, but we'll see what he has to say. I mean, this is America. We're a democracy, and I yield.